Yo! All right, thanks for listening. I'm Eric Hansen. Today we're talking with Brett Jarosz and Scott Wustenberg, so two of my favoritist people in Australia. Brett's a super chiropractor. He's got a really cool way of approaching things. He's very much not a one-trick pony, multimodal approach, which he speaks very eloquently to in today's podcast. Brett, he's won Chiro of the Year a couple of years ago. He's really well versed in the neurology behind rehab as well as how your brain works. Guys just studied it all. And what's really annoying is I was having a chat with him about this off air, saying that you're making me feel bad because you've done all this stuff. And then I found out that he graduated out of chiro school 2 years after me. And then he goes, yeah, no, I'm actually really lazy, which is worse because if he's lazy and he's done all of that, then I really need to get my act together. So today we talk all about what Brett did before and after he had a hip replacement. Now, it's really interesting from a rehab point of view, finding out what to do before surgery and then what to do after surgery. And then Scotty weighs in about what to be done from a nutritional side of things to help with the inflammatory aspect to getting better. Enjoy. Have a listen. Right. Ready to rock?
Absolutely. Good morning.
Good morning. So, for people listening, we're joined today by Brett Jarosz. Mate, I was reading your website about 10 minutes ago. Have you ever read someone's biography and just started to get really pissed off? Mate, is there anything you haven't on them read? You were chiropractor of the year, and then you've done this, and then the kicker was you graduated 2 years after me. Bye, hi. I'm like, Jesus, what have I been doing? Damn it!
You think you've got problems? You guys are both like a decade younger than me.
So for everyone listening at home, Brett Jarosz is the king of chiropractic as far as I'm concerned. Is there something about being bald that makes you a really good chiropractor, Brett? I'm just wondering if I should start shaving my noggin down.
No, I purely think that it comes from my mum's dad, because everyone in our family has been bald, I think, or starting to go bald since our late 20s. So, except for my brother. My brother's the one that's been genetically blessed, and he's obviously taken right after my dad and has a full head of hair. And apart from that, mate, there's I don't think, because a lot of the brilliant people, the brilliant people that I know within our profession, most of them have hair. They might be thinning, but they have hair.
I don't know about that. I mean, there's you, Brandon Brock. He's losing it up top. Scotty's thinning, whether he wants to admit it or not.
Oh no, that's why it's down short. It's gone. There's no point doing the comb over. My name's not Trump.
It's just that extra vitamin D absorption through your skulls is improving your brain function or something. Either way, we'll have to test it out. Mate, how's your hip rehab going? Because you just had a hip replacement, didn't you?
Yeah, I did. Yeah, the hip's going really well. Good learning experience. There's a few things about the procedure that, as you guys are aware, I've been fortunate enough to be working in that sort of corrective exercise and rehab world for a number of years now, and I've done a lot of post-surgical hip replacement rehab programs with people, but having it done yourself, and even though you're aware of these things, a new procedure gets performed on yourself, and the anterior hip replacement is what I had, and finding out from the surgeon, I was going through some interesting experiences where I was actually watching my left quad atrophy. Ooh. And for me, I've been blessed with pretty good quads, actually, thanks to my dad. So I've never really had to worry too much about whatever happened with my quads. I could train them and they were just always there. But watching my left quad actually atrophy and looking in the mirror and seeing it visibly, I sort of felt it. But then when I saw it in the mirror, I'm like, geez, that's actually shrunk. And I, with the feeling that I had, I just had this deep, weird feeling inside my thigh, and it was the only thing that I could just explain was this deep, weird feeling. I could feel swelling up where the incision site was, and that's, of course, normal, but I just felt this deep, pressury, weird sensation inside the middle of my thigh. And when I had my post-operative consult with my surgeon, And he had said to me, where the implant and the bone are actually where the implant's been drilled into your bone, he goes, that bleeds for 4 to 6 weeks.
Oh, right.
And I had no idea that it bled for 4 to 6 weeks. So as soon as I heard that, I'm like, well, that makes sense. So I'm feeling this like swelling that's occurring, deep around the femur. And that swelling was causing a reflexogenic inhibition of my quad, and my quad was atrophying. And so at about 5 weeks for me post-operative, the swelling, that sensation started to feel like it had actually begun to dissipate. And then when I was actually doing my rehab and corrective exercises, my quad started coming back. So I've just been pretty much honing in on that. We did some dynamometry testing on my quad and on my hip about 3.5 weeks ago, which I want to follow up next week. And we found out, my left quad was 23% weaker than my right, and my left hip abductors were 35% weaker, which we expected, of course. But when you've got the percentages and those objective measures, of course, we can start going after it. So the last 3 weeks, my rehab program's been very much directed towards normal post-operative plus the specificity of where my deficits are. And we'll check it next week, find out how I've gone, and we'll look at progressing and improving and further focusing and targeting to.
That's actually.
But everything.
That's a lot less loss of strength than I'd have expected, considering the amount of trauma both prior to and the whole surgery in of itself. You kind of.
Yeah, it's an interesting comment there, Scott. The one thing I was going to sort of suggest, I think part of it actually has to do with the procedure, because the big call with this new anterior muscle sparing technique is they're cutting you on the anterior hip, and you're actually not damaging from an incision perspective. You're not damaging any of the actual musculature. You're putting the forceps in there and basically separating between the TFL and the sartorius, and they're going in there between that. So you've got a faster recovery because of the fact you're not really altering any of those dynamic joint stabilizers per se. It's, you're damaging the capsule, so you're obviously cutting the capsule and opening that up, and you're losing obviously articular proprioception and mechanoreception from the articular surfaces, which have already been damaged, of course, because of the degeneration that had occurred in my hip. But I also think the other flip side of it too, Scotty, is whether we go into this argument of using this word prehabilitation, because there's a couple of arguments out there of what prehab means, because prehabilitation, when because I referenced it in a couple of the articles that I wrote about 8 years ago, were prehab at that point in time was when you did corrective exercises or particular exercise strategies that was leading you into your surgery. And then you were doing that, and they were starting to show that minimized surgery complications and risks. It helped speed up recovery and a few other little factors that were there. So if you did the work before the surgery, they tended to find that the surgery tended to be a little bit more successful. Now, that was the way that I had seen the word prehab, but it's being used in various forms nowadays. But prehab to me is the work that you do before a surgery. And the thing is, we need to have that word defined. But I think that's the other part of it, Scott, was I did that, and we, with a good surgical technique, the muscle sparing technique, a great surgeon, and having done a lot of the prehab work leading into it, despite, the orthopedic, tissue damage that was there, the pathoanatomy.
And with
I think that in combination
with regards to your prehab work, what were you doing? I mean, obviously I've been through the FNOR course, which has been brilliant. But for the preparing yourself for surgery,
the checks in the mail on that one, dude. Just putting it out there. That was
Scotty. Pipe down, buddy. Every other bloody week, I'm giving you props for all of your magical concoctions. It's time for me to tell someone else what they're doing. Settle down, all right? So back to Brett. So the FNOR course has been amazing. But what sort of prehab strategies were you? So if anyone's listening and they're heading in for surgery. The temptation is, I don't want to do anything because it's just really sore and I'm going to get the surgery and that's going to fix it all, anything. But how do you approach a prehab knowing that you're heading towards surgery?
Yeah. So for myself specifically, and then I'll try and maybe generalize it a bit. So myself specifically being a hip-based pathoanatomy, I targeted, the area around the hip. So went after just the glute max, went after the glute med complex, and really was targeting those guys, and just did a lot of heavy isometrics and just purely non-weight bearing. Because the one thing I was finding is if I did too much weight bearing work, that would flare it up. So, and as we know, like you start to generate, joint-based pain or joint swelling. We're aware of this phenomenon. I wouldn't call it a phenomenon, but we're aware of this pathophysiological response, which is called arthrogenic muscle inhibition. So if you get joint pain or joint swelling or damage to your mechanoreceptors with the capsule, articular cartilage, etc., we know that the muscles around the joint have an alteration reflexogenically, and that pattern is that the flexors around that joint start to become facilitated, and that the short extensors classically start to become inhibited. So your anti-gravity muscles, the muscles that help you stand upright. So if we look at the hip, your glutes become switched off and your hip flexors become switched on. Very simplistically, if it's at your knee, your quad becomes switched off, and your hammy, your calf, and your popliteus become facilitated. Ankle, similar principle, peroneals become inhibited, tib anterior. There's an argument at the ankle whether or not we change the words to arthrogenic muscle response, because the extensors that switch off aren't consistent, but the soleus does switch on, and we're aware it happens in the shoulder as well, where you get into that flexion response and your infraspinatus becomes inhibited. So the thing for me is when someone's going in for a surgery, I'm going to look and knowing that neurophysiological response will be there. So I'm going to go after the muscles that we want to try and facilitate within a patient's pain comfort. So we're not talking about if the muscles are starting to feel burny and sore because they're working out. We want that. We want to make them work, but we don't want them to be reproducing and exacerbating their pain symptoms. So we don't, because otherwise that pain symptom is reflexively genetically turning off what we want to turn on.
Yeah.
And when
you don't really want that.
Yeah, so I just went after my hip.
Don't want that pain.
So I went after my hip in a hip in a non-weight bearing position for me was the best position for me. So I just drove that. And I would do that at least once a day, often twice a day. And then once a day, I shouldn't say that, once every second day, I was actually on the ergo rower. That was probably the only cardio equipment that I could actually use at that time. Now, don't get me wrong, I wasn't doing it technically correctly like a rower. I was letting my knees fall out to the side. But you put me on a spin bike, that would aggravate my hip. Walking was aggravating my hip. So I was on the ergo, let my knees fall out, and I was able to go on the ergo. So that was my cardio approach. So I just literally blast my hip and go after my glutes with isometrics, with some isometrics with these alternating action control movements, Eric, which you've learnt through FNOR. Did some eccentric work as well, with all from non-weight bearing. Would do somewhere between 10 and 20 minutes of that, jump on the ergo, and I'm fortunate I've got a colleague down here who used to be a pretty elite ex-rower, and he writes some rowing programs for me. So every second day I'd get on the rower and follow up the glute session with that. So that was my prehab program for me specifically. And as a general rule for my patients, depending on what their injury is, we specify the muscles that we want to activate. We look at anything that may be tight and restricted from a mobility point of view that we can go after, so they can do some mobility work to those regions. We do the activation work, and then depending on how much time we've got, we try to see if we can integrate that into whatever functional position. So if we can get someone who's got a knee surgery coming up and we can get their quad working, and then all of a sudden we find out we can remove the quad lag potentially on testing, and then we can maybe get them up into doing some squatting and things like supported squats and things like that, but wall squats and wall slides, and get that technique going and get them learning that in a functional integrated position, get them doing some cardio as well, and just try and build up a bit of their cardiovascular capacity, build up that muscle tone and activation around the area, build up the brain maps, basically, for that area, so their brain has a better map of that area, and then go in for the surgery.
To that point, so with the strategies that you've mentioned, I mean, the very sort of like isometrics, and the arguments made that you can't really divorce muscle feedback from joint feedback, but do you do any sort of joint-specific proprioceptive retraining work pre-surgery, knowing full well that they're going to chop it up and it's going to get blasted to bits anyway?
So that would come into like my mobility section, dependent upon whether or not those movements actually exacerbate a person or not. So, because if it's driving pain for them, then to me, in my just clinical opinion experience, like when you drive that pain, you're making your job harder to then switch the muscles on that you were trying to switch on. So if they can do movements, absolutely agree with you there. It's like trying to get that awareness of that joint as best you can, but keeping in mind that those mechanoreceptors and proprioception from the joint itself is being altered because of the actual.
Do you use much in the way of laser on it?
In terms of prehab or post?
So especially turning off pain, I found that really useful, and especially towards the muscle lag.
Yes. Yeah, so fortunate enough, I know the three of us have all got lasers, and so yes, I've had a couple of phenomenal responses actually with laser that I just haven't seen in practice. It's it's one of those ones where you see it, and as me, I'm you guys know me well, and I'm influenced very much by what the literature says, and not that I, recipe approach what the research says, because that's the other issue, because if you just copy what the research says, that just turns you into a technician as well. It's like following any technique system. So your job is to read the research and critically appraise it and apply it to your patient that's in front of you. So with laser, when you look at the research, there's some phenomenal stuff out there. But for me, before we get into that idea of prehab and rehab, just to share that story, I had a grade 2 hamstring tear come in to see me that was 3 days post-injury. So came in, obviously not a very normal gait at all. Of course, their swing phase was obviously limited, so where initial contact was not very far in front of their body, so their stride length was limited. It was obviously painful. So gait alteration, shorter stride length. And then when you go through your various manual muscle testing, so the hamstring was 4 out of 5 when you manually muscle tested it at 90 and at 15 degrees. When we did like your glute max, short lever and long lever type muscle testing, they were 4 out of 5, all of them reproducing the person's pain. There was bruising there was a palpable defect. So to me, I'd sort of grade those little palpable defects there in like between grade 2 and grade 3. So a mentor of mine, Rick Ames, down here in Melbourne, he grades strains into grade 1, grade 2A and B, and then grade 3. And so I always, in my mind, when I feel a palpable defect and you've got the other criteria that's fitting a grade 2 strain, I tend to make that idea of that palpable defect with all the other criteria of a grade 2 that fits to me into a grade 2B. That's just how I look at it clinically. So yeah, this guy had a grade 2B, and we ended up lasering the area for about 10 minutes, sort of 2 minutes in each particular, playing card region, isolated a playing card sort of distance or, surface area, 2 minutes there, and then just worked through the area and around the area. And after the laser, and again, to me, if I didn't see it and do it, I'd still be like, no, that didn't happen. But every muscle test was 5 out of 5 and pain-free. He got up and was limping. No limp, I should say. The limp was gone. He had normal gait. And I was just blown away. No. Of course, that doesn't mean he's fixed. You got to rehab him, but just blown away with the changes that laser made. Had a same response with a grade 2 soleus tear that I lasered 4 hours after it had happened. So I've seen some crazy stuff musculoskeletal with it, and yes, so I did use it prehab because that would definitely help with pain that I noticed on myself personally, and yeah, I've been using it daily on my hip myself post-surgically. So it's become sort of more every second day the last week and a half, but yeah, up and
is it for post-hip hop? Oh, you're breaking up a little bit there, mate. Hear me?
You're breaking up a little bit.
Ready, Brett?
Sorry, mate, just broke up a bit there.
Got me now.
Yep.
Heaps of studies looking at the laser on post-surgical hip replacement from a incision healing rate as well as the restoring mechanics. Did you find that same accelerated heal rate in the incision site?
Yeah, my scar, the first thing was where the scar actually was, you've got the waterproofing protecting on it there for a couple of weeks, so you can only really laser around it. And then, so I've got no way to actually judge how that incision site looked. But
you can actually go straight through it.
And then after that, they put the steri strips on there, and they last about a week. So again,
Yeah, absolutely.
Waterproofing.
Think how big a photon is.
Is that
Yeah,
Scotty?
absolutely.
You
You can go straight through pretty much any material. You know, there are certain things that, like if you had a lump of steel across it, it probably won't bounce through. But a photon's pretty damn small, and it will go through the actual the holes that are actually still in that tiny coating. I was speaking to some of the laser trainers coming out of the States, people who work for Erconia, and they were saying, look, you know, it's going to take you a bit longer to get it through other materials like clothing, etc., but you can go through the bandages quite happily.
Yeah, cool. Well,
yeah, but it won't make much difference to you, but
remember that if you ever have to have a surgery
for other people.
Next hip operation.
Yeah, absolutely. No, appreciate the heads up with that. So, yeah, but once I put the laser directly over it, those like the surgical site had healed really well, even though I wasn't doing it directly over the site. The surgeon, when he took the water proofing off, he was like really happy with it. Like there was literally only 2 little keloid areas, both at the proximal and distal end of the scar, that were just a little bit elevated. And now that I've been lasering directly over it, there's just a little bit of it left. So it's really good looking scar. It's healed really well.
Matt, one of the things I wanted to ask you about, because I mean you've got a very similar philosophy to me about approaching complicated cases where collaboration is vitally important. I mean, when you look at things like concussion, if you're just doing it from a chiro only point of view, you're missing it, or everyone's got to work together with some of these complicated ones. So for a hip replacement, obviously with your training you're covering sort of multiple approaches just on your own. But in your experience, I'm trying to find the politically correct way of saying this. It's a sort of multidisciplinary approach for someone doing a hip op. If they didn't have access to someone who was doing done the FNOR course. The question is physio's got its place, of course. You need to be collaborating with GPs, MDs, and what would be the ideal rehab strategy post-surgical hip replacement, do you think? Or who should be weighing in?
Well, not necessarily who, because obviously there are practitioners out there that have gone above and beyond necessarily what that, their professional training. It's one of the interesting conversations I actually had it this week with someone, that idea of, like they go, if you treat a particular condition, does chiropractic help that? And I go, well, can you define what chiropractic is for me? Can you define what physiotherapy is for me? Can you define what osteopathy is for me? Because in the end, to me, we are all the same. And it's just there's a variation in the material that's delivered to us at university, and we tend to have a bias towards a few more techniques. So chiropractors spend 5 years honing their manipulative therapy skills, and as a result, there's a perception out there that chiros are, so you say the word chiropractic, and people just think back and neck crackers, including me. That's how I used to think of our profession. Physios will go and do a 1 year master's and become, get a master's in manipulative therapy, or it might be a little bit longer than that, but they can go and do, a year or 2 year postgrad in manipulative therapy and hone their skills with it. The osteos do manipulation too. Chiros spend more time doing high velocity, low amplitude. The osteos do that as well, but they spend more time doing long lever manipulation than what we would do as chiros. So in the end, I feel that there's components that we're all the same. We have techniques that we may be a little bit better at than one another because we spend more time training at them. But then again, once you graduate, you can go and then do postgraduate seminars and training, and with that training, you can hone your skills and become better at that. Like maybe, chiros go and do some more dry needling, and they become better at doing dry needling. They go and become better at doing their soft tissue techniques, maybe instrument assisted. maybe different taping techniques, and the physiotherapists go, well, yeah, I've already done a lot of this, like biomechanics type of work as an example, and they go, I want to go and learn how to do a little bit more manipulation. I want to go and learn how to do exercise therapy a little bit better than what they felt they got taught at their university, and the chiros might think the same. So I think what ends up happening is that you can go to any practitioner that is evidence-based, that wants to serve their patients. To me, and you guys have heard me say this, this idea of, so just being this idea of this multimodal management approach, and it's individualized to the patient that's in front of you. So you can't follow a research article. A point that I try to polarize is, if you look at a research article, what's the purpose of a research article? It's to remove any factors that are going to mess with the data for the hypothesis that you are seeking to answer. So if I want to find out what's the best way to activate someone's, let's just go with like their quad, and they've got knee pain. So the example being here, what's the best way to fire someone's quad, or what's the best way to fire someone's hip in terms of specific muscles? So let's put EMG in there, and let's put a needle EMG into these muscles. Let's measure how those muscles fire. But if I've got a patient that's got hip pain, if I've got a patient that's got knee pain, someone that's had back pain, or whatever it may be, previous surgeries, etc., those muscles are going to fire differently. And as a result, that's going to mess up my data, unless that's the data I'm looking for, is how do these muscles fire in injured or previously injured paper. But if we're trying to find out how these muscles fire best, and what are the best exercises to fire those muscles, I remove the people that are going to screw up my data. And as a result of that, when you look at the research and someone says, these are the best exercises to activate your VMO, or your quad, or your glute med, or your glute max, and you got to remember that that's taken on quote unquote
and it's skewed.
People. Now there are some studies out there that go, this is a glute med tendinopathy, or this is a patellar tendinopathy, or this is patellofemoral pain syndrome, and these are the best ways to make these muscles activate. That's targeting that specific population, but is that the patient that's in front of you? And so that's the whole idea. We're going to take that research and go, does that research truly apply to my patient in front of me, rather than going, oh, I need to activate this person's, like quad because they've got knee pain. We know their quad's being switched off. We've got to activate their quad, but we've got to look at how we take that research and apply it.
The great thing I always want. Oh, that's okay. The other thing I want people to think about is how they got to that point that the quad was turning off is going to be different in almost every case. So the how is equally as important, if not more so, than the what. Because if you don't understand the mechanism of the how, then the data that you're looking at, that you're about to apply, may be completely irrelevant to the patient that you've got in front of you. And so you've always got to look, in my opinion, a lot more big picture. And of course, my favorite thought in there from what you were saying about multimodal is, to fire a nerve requires those three major things. You've got to have your gas exchange, your stimulus, your biochemistry working. And if you're not capable of looking at the other factors because you're really good, and I'll just use the term cracking bones or stimulating muscles or rubbing something, then you need to collaborate with those other people to make sure that the tissue that you're dealing with is actually going to get the appropriate stimulus, rather than just the hammer that you have in your hand. There's my rant.
Agree, Scott, and that comes back to Eric's question, which we sort of were expanding upon. But it's like, what's the team? So if you've got a practitioner that's multimodal, they've gone and done further training, you might find a practitioner that can pretty much be almost a one-stop shop for you, because they've got the training, they've got the qualifications, and lucky patient, and great for that practitioner. They've been continuing to work to serve. To serve humanity, serve the public. It's, to me, that's... No, and just so that next step is, but let's just say someone goes, listen, where I want to work in my practice, and this is where I want to be really, really good at, and they go, all I want to be really, really good at is I want to be great at manipulation, as an example. And then that person then goes, well, I'm aware that manipulation is a very valid technique in certain circumstances, as long as Scott says, we assess the whole. And so you look at it and you go, does that joint really need to be manipulated? Does that person's nervous system, would it benefit from being affrontated with a manipulation, or would it be too much, etc.? So we determine that, and then we go, right, that manipulation is appropriate, but now I need to go and have this person learn how to activate that muscle, learn how to integrate that muscle into normal, functional, foundational movement. And, also, this person's anemic. Well, I better be dealing with the medical practitioner or the the naturopath or the nutritionist or the Scott to deal with the biomedical and the functional medicine type of approach of dealing with that anemia. Because as you said, like if someone's anemic, good luck on making that rehab continue to work, because they're just going to fatigue out.
And then you get fallout in so many other areas.
Functional neuro work on someone who's anemic.
It's just terrible.
Sorry, I got both of you talking there. I caught a bit of Eric saying about annoying with anemia on functional neurology.
You're just saying that trying to correct a sort of functional neuro style case if they've got anemia. Before I was looking at these things, you can. It's 6 months instead of a couple of weeks, and then Scotty says, "Hey, maybe you should look at bloods." And they're, "Oh, look, they're anemic. We should fix that too." Mm-hmm. Surprise, surprise! Most of the brain symptoms go away after that.
Wasn't my fault.
Yeah, well, I mean that's definitely where we get Scott. That's where we get Scott starting to talk. I was about to say starting to get Scott to start to talk now, because I think, and obviously Eric, you and I both send people to Scott. I just sent another one to Scott last night to have further just assessment with what they're doing from their metabolic and medical and then the functional nutritional medication interactions and integration, that idea of looking at that holistic picture. Because, if we miss that metabolic component, and that's the underlying driving factor, we can try and do the active therapy to the musculature, to the nervous system, to whatever it is that we're going after. But if they don't have that fuel there and that ability to transport oxygen, such as in anemia, and we're not getting the oxygen to where we need it to go, and then, as we know, iron's involved in all of your neurotransmitters and all of
mitochondria
that it does, we're not going to really get too far with our rehab, and the person's going to go, why aren't I getting better?
You ain't got nothing to support yourself. It's so true.
There is that argument. So with therapists who do follow down the rabbit hole and go, look, I'm going to be a super specialist. I'm going to be the best neck adjuster in the world, and like there are people out there who are brilliant adjusters. But then you get people like myself, who I would consider much more of a multimodal, and while I might not be as proficient as the guy down the road who's a brilliant adjuster, so we both call ourselves chiropractors. So from an identity point of view, the public perception, chiros just crack things. Brett, how do you sort of get around is that just your reputation getting out there where it's like, no, Brett's the multimodal guy, he'll figure it all out and put it all together for you, versus, this guy is the best neck adjuster, so that they're both called the same thing? Care to weigh in on identity?
Yeah, it's a tough one, Eric, and I know, there are a couple of things going on in the background right now that I do know that are happening in this field. We should start to see some announcements officially coming out in the next couple of months.
That's exciting.
But it is exciting. But the idea of identity, it's for the public's, I came from that background where all I thought chiropractors were back and neck crackers. And as a result, when I was a kid and I played sport, the reality was for me, that was me and my family all had that perception. And as a result, I was like, no, I'm not seeing a chiropractor as an athlete. I need someone that can do more for me. And that was just how I used to perceive it. And you got to remember that patient's entitled to that perception and that opinion. So the thing for me was, when I met Rick Ames, my mentor, and very much a multimodal practitioner, I was blown away. I was like, wow, like look at all this knowledge, look at all of this approach to trying to use the appropriate management approach for that particular presentation, and it just resonated with me. And when we look at the literature, that's what the literature suggests, that we should be, multimodal and try and utilize the appropriate management tool for the appropriate presentation. And the whole thing is like one technique does not fix everything, because otherwise we would all be at university learning that one technique, because it would solve everything. So, the reality is manipulation doesn't fix everything. Soft tissue doesn't, exercise doesn't, nutrition doesn't, medication doesn't, surgery doesn't. We're all a team. And that's the whole thing. It's like we are all part of the healthcare team to serve our patients. And so, again, if you know that there's a hole in your knowledge, you either start to go, I've got to go and learn more about that, which I encourage everyone to do. But at the same time, you go, I go and find a practitioner who's really good at that, and I start to network with them. And then we can go, I've got this patient I need to send to you. You talk to the patient about why we're referring, and that patient goes over to your colleague, and your colleague does their great job, and they know where their role in that patient's management is, and then they you cross refer to other practitioners, and it's all about getting that patient better. No egos involved. It's patient centered. So that idea of taking evidence based and making it patient centered, I like that idea of like patient centered, evidence influenced, multimodal management care.
Love it.
Mate, that is beautifully said. So, mate, from so obviously with the hip hop, we're doing all the right things from a post rehab musculoskeletal activation, get your gait walking better again. What would you be doing outside of that from a nutritional point of view, and or what else would you be adding to the mix other than exercise?
Yeah, that's it. Yeah. Good question, man, because I'm going to definitely go and defer this over to Scott as to what I should have been doing, but what I ended up doing, because the one thing for me was leading into my hip operation. Unfortunately, and a lot of the listeners out there that may listen, and for people who know me, are aware that I had to go through chemo for cancer. And when I went through the chemo, though, the dexamethasone that I had to go on made me put on a lot of weight, and I put on between I shouldn't even say 8, it's probably more like 10 to 12 kilos is what I put on, and I could never shake it. And the one thing for me going into the surgery as part of my prehab, is I was trying and lose as much as that weight as I could effectively. And so that was my first approach, was to see if I could do that. But then once I had the operation, my approach was to make sure I was putting in the appropriate things to try and help healing, to try and help like the inflammatory process, not in terms of like stopping the inflammatory process, because like my attitude is we want that there. The inflammatory process
modulating
is supposed to be there, but we want that inflammatory process to do its job properly and not hang around. So my thing for that was I was like putting a lot of collagen protein. Scotty can rip me apart here with this. This is fine, but I was putting like just collagen-based proteins into myself, and your various like your vitamin D's and your fish oils and your and the zincs and just really trying to go about healing and just putting good quality proteins and good quality fats into my system, and putting a lot of just greens, avocados, your broccolis, your cauliflowers, all your kales and bok choys and all that type of stuff, being pretty heavy with that type of approach. And with the nutrition after that, then after I'd started to get to that point that things were firing well and that sensation had gone after about 5 weeks, I actually then started going back to some of my intermittent fasting again. It's something that I have done ever since cancer, and I brought that back into play. So, Scotty, chew me out. Tell me what I should have actually done. Why I didn't do it in the first place is beyond me. So,
well, that's probably is the effects of the survival mechanism. Look, I'm facing something serious. My brain is just going to deal with what I can cope with, and I can cope with this. And I think that's a really sensible approach. Everything that you did is good. I love collagen as a product. You just got to be aware that everything that you're consuming, your body's going to digest. So all that collagen protein is going to get chopped up into its amino acids, sucked into the body, assuming your gut's working well. And then we kind of got to hope that it's being redistributed effectively. So I really like it when you're using kind of pure amino acids at that moment that actually make up the collagen in the first place, using your glycines and glutamines and pre-digested proteins a little bit more. The other things that I'd probably have wanted you to look at, again, I think you were, because we already put you on things like the broccoli seed extracts originally, because again, they're really particularly important for lowering that and modulating the NRF2 pathways and decreasing excessive inflammation at that moment, as well as driving a leveling out of your detoxification pathways in both the gut and the liver. The other things that I'm looking at, I'm trying to get a new product made at this moment to really try and modulate NRF2 and the RRE pathways that are going to lower excessive oxidative stress without creating reactive oxygen species. It's going to kind of have, as you were talking about, vitamin D, a group of B vitamins, some vitamin E in a couple of different forms, vitamin A, N-acetylcysteine, which is particularly important for making glutathione, alpha-lipoic acid, which is one of my favorite antioxidants because it will also cross the blood-brain barrier, and it's one of the few things that can get the reactive oxygen species as well as heavy metals out of the brain. So for patients that you'll be seeing post-concussive syndrome, this is one of the best antioxidants along with coenzyme Q10 that we can use to really get that brain fog, oxidative stress down and try and get their heads working, because they're both particularly important for making mitochondria work properly. We really want to be in those moments, especially driving a decrease in oxidative stress, which is what drives inflammation. We've got to be really careful with the metals, the zinc, which is essential for healing. If we're putting it in unabated by other, non-metal antioxidants, it can actually have a destructive capacity, because it's one of the things, copper and iron and zinc can be used by the immune system to actually make peroxisomes, and the body uses them to actually torture bacteria when there's any signs of infection. So unabated metals are actually kind of a dangerous thing. I get my patients to think of them a little bit like steak knives, really useful for the intended purposes, but don't leave them lying around for the kids to play with, because you're going to end up with some unexpected consequences. L-carnitine's my other favorite one. Again, really essential for driving down oxidative stress, but also essential for getting the fatty acids into the mitochondria and actually burning them to make the energy. Because no matter what we do, in every wound, whether it's a bang to the head or a surgical incision, if your mitochondria aren't working tip-top, you're in a world of trouble. And that's a really interesting point, as we were speaking about with regards to iron. We've always got to keep our patients in mind when we're complaining about anemia and iron deficiency. And so iron deficiency is that subclass where they haven't really gone across the magical pathology line. Instead of being like 5, they might be at 7, right at the very bottom end of the range. For every mitochondria to make energy, you require 4 molecules of iron. So iron has this massive, massive drive to keep everything operating in the body. And without enough of it going into you, you're going to be in a world of hurt. That one gets really, really important when you're going to have a group of patients come in, because it's particularly popular at this moment that they're going to be on a low animal source diet for their proteins and their iron intakes. And so if they come in injured, their ability to heal is going to be very, very difficult. They're going to be low energy, low hormone, low neurotransmitter, and they're not going to want to actually take on board the fact that maybe their diet isn't quite established in an appropriate direction for their best healing. So that's a conversation that we all as practitioners need to be aware of, and try and actually get patients thinking about what their best health and well-being is. I like to get patients to actually think, well, remember, you're an animal too. And if you want to be nice to animals, maybe the first one to start with is yourself. I just had to throw some controversy into that.
Just saw a funny photo where it was cheetah, meat eater, tiger, meat eater, and then it was looking at vegetarians. It's like hippo, cow, and it's like, which one do you want to look like? It's like, eat meat.
I love it.
But Scotty, with all those things that you just mentioned, were they all driving down inflammation or modulating inflammation?
So they all have a free radical scavenging capacity. Now, what we're basically trying to do ultimately is modulate free radicals and modulate inflammation. If you suppress all the oxidative stress, you're going to actually block the NRF2 pathway and actually stop the long-term healing, which means that, as Brett was alluding to, if we don't allow some inflammation, the party just keeps going because you don't kick your other interleukins into play. So you need your interleukin 10. You need the teachers to come along. I kind of get people to think about it a bit like you're at high school and there's a fight between a couple of guys. And, everyone swarms in there as soon as there's a fight, and they're all going, fight, fight, fight. And then, that's all your interleukin kind of 1 betas and NF kappa Bs and all the stuff that drives the inflammation, and it increases the body's awareness of the site of injury. But things kind of slightly later on that are meant to come in, like interleukin 10, are actually the teachers going, right, that's enough, break it up, party's over, let's get this all cleaned up and put away. And so if we block the teacher being able to come into that situation, we're not going to be able to actually drive it to appropriate endpoints. And that's where we get the situations of failed apoptosis and failed healing and bad scar tissues and situations that we really don't want. Perpetual, post-concussion syndrome and the glial cells becoming really, really ramified so that they overactivate in the brain. So, you've got to modulate it, not shut it down.
Are there supplements that you recommend for immediately after a concussion or a hip replacement or surgery, or you've torn the crap out of your rotator cuff or whatever, and then a different set of supplements for that time when you do want to sort of start squashing that inflammation that's hanging around longer than it should?
Yeah, absolutely. So the vitamin D, vitamin A, vitamin E, and the fish oils. So, like, you could use a cod liver oil as a really good place to start. Coenzyme Q10 is another one of my immediates. These things are very good for mitigating the negative impact without stopping it altogether. And if you get in there too quick, especially with something like a concussion, and you blunt that entire effect, you actually keep it in situ for a whole lot longer, and this risks the post-concussion syndrome. So from that injury, we actually go very mildly, and what we're really trying to do is much more towards up-regulating detoxification pathways. So I'd use my broccoli seed extract, the sulforaphane, as it's going to improve your vitamin D use, it's going to improve your anti-inflammatory production, and it's going to mitigate excessive interleukin 6 and tumor necrosis factor alpha without stopping it. So we don't want to stop it, we just want to stop it getting out of hand. Like a teenager's party. You only want to keep like 10 people around, you don't want more than that turning up.
That's brilliant.
You'll see.
So if that was the appropriate nutritional point, because I know you've got a cryo chamber in your clinic, would that be something that would be appropriate for a post-surgical case like Brett's, or at what stage would you consider other things like cryo or insert extra whole body anti-inflammatory?
Yeah, so the two devices that I would look at for controlling inflammation, because the literature basically shows, three things that I use are, I use photobiomodulation, I use low-level laser therapy, I use cryosauna, so taking people's whole body down to minus 190 degrees, or the unit is measuring that. Their whole body isn't going to be down at that point because they'll get tissue damage at that moment in time. And I would use hyperbaric oxygen chamber, so low level again. And again, the data shows in the literature that hyperbaric oxygen provides more oxygen to the tissue, and this helps modulate that inflammatory response. And we're trying to get blood supply back into areas, and this might have been a really useful thing for Brett. If we can oxygenate the blood tissue better, we might find that his rate of healing speeds up. And again, the literature is particularly good for showing that. It's particularly good in the literature for post-concussion syndrome and wound healing. And so reperfusion injuries are very similar. So all surgeries will have a risk of reperfusion injury. As soon as that blood supply comes back to the area, we get this big rush of oxidative stress coming in because you've taken the oxygen away and then you pumped it back in to an area that was anoxic. And that's where that free radical damage starts kicking off. So hyperbaric's been shown by increasing the pressurization of oxygen into the tissue, and at 1.3 atmospheres, it's somewhere around 5 times single room sea level atmosphere oxygen perfused into the tissue, and that seems, according to the literature, to be particularly good for decreasing that free radical damage going on. And that's, again, similar things going on with whole body cryosaunas. You're going to find that by getting the cold into the system, what the body does is it shrinks all the blood supply away from the peripheral tissue as the normal genetic sirtuin defense systems and survival systems kick in. You then take the cold away very suddenly. You go from, like in my office, 25 degrees to minus 190 to 25 degrees again, and it pushes all the blood around the body and reoxygenates the tissue. But because you haven't had it out of the tissue for very long, there's a much lower risk of free radical damage having gone on. Now, again, I might not be too keen on, without a lot more knowledge about what, say, Brett's prosthesis is made of, on making his body want to go to 190 degrees below zero. Because I don't know why, but that just doesn't sound like a world of fun.
Find out if I'm
yeah, that's exactly it. Not so keen on that. But in general, for someone who's had surgery that doesn't have a more solid object placed into the body, taking the tissue down, lowering the NRF2 pathways and actually driving a reduction in oxidative stress is going to be particularly good. It's shown again in the literature to reduce swelling, to reduce inflammation, and it stimulates all of these treatments that I use are shown in the literature to drive epigenetics to improve the sirtuin genes and the survival genes. And really, I think what most of our treatments, if you look at the rehabilitation pathways, anything that drives the epigenetics to actually improve your survival outcomes generally gives us a better response, whether it's getting more oxygen to the tissue, lowering inflammation, connecting a brain pathway to a muscle. Anything in that fashion works. Well, that's what the literature says as far as I can read from it. And again, similarly with supplementation, most of the things that are shown to work have an epigenetic effect on the body, decreasing inflammation and increasing blood supply, increasing the sirtuin genes at that moment. Anything that blunts inflammation completely generally is shown not to work. And that's where, like 10, 15 years ago, they came out with that literature that they were giving smokers really, really high doses of retinoic acid, and they had to can the actual study because they were killing their patients. And what basically worked out is that the vast high level was actually driving more reactive oxygen species in there. And as it turns out, the type of vitamin you use is actually particularly important. Like if they'd use vitamin A versus synthetic retinoic acid that have had a different response, you actually get more reactive oxygen species being created in a low oxygen environment from the carotenoids than you do from true vitamin A. It's fascinating stuff from my point of view, but not everyone's going to get it.
Mate, you've used enough big words on me again to make me realise that as soon as there is a biomedical style approach, I'm just going to say, hey, look, go talk to Scotty. He'll sort it out. But Geez, very much from
Thank you.
Multimodal rehab plus biomedical, and don't be silly with anything. That's,
Cool.
Mate, I think we're almost at the hour mark, guys. We should start to. I really need a coffee. Closing remarks, Scotty and Brett, before we part ways.
Go the Patriots. Doesn't matter.
It's the Eagles and the Falcons. It's the
I'm up for the Eagles
today,
at that moment.
Yeah, I'll support you there. The guy I'm playing in fantasy football is starting Matt Ryan against me today, so I really hope you're right. Go Eagles.
Yeah, absolutely.
Fly.
All right, guys, this has been a lot of fun.
Awesome.
Mate, Brett, thank you for joining me and Scotty for our Friday rant.
Oh no, appreciate the invite, boys. Yeah, no, appreciate the invite. And as I said, when I found out two guys were doing a podcast, I've been jumping on and listening from the start now and making my way through. And you guys are, producing some great information for patients to be able to listen to and be able to educate themselves, to be able to know that they can go and learn more. And there's research out there from obviously medical and allied health perspectives, and just remember that we all hopefully are working together as a team to serve the public and the patient, and in the end that's our ideal thing, be that patient-centered,
awesome,
evidence-based,
and we've managed to keep our shit together today really well, Eric.
Don't swear, and then don't say anything political.
Gotcha.
We did well. All right, guys. Beautiful. So I hope you all enjoyed that, including Brett's bloody cats, that if I ever see them again, I may eat them or something. If you want to get in touch with me, I can be found in Sydney, Eric at brainandbodyhealth.com.au or 98176611 is the best way to find me. If you want to talk to Scotty, he's up in Queensland, so you can be found on 07337102222. Or if you want to get in touch with Brett, he's down in Melbourne and he's amazing. He can be found at 0398262122, and it's Optimized Sports Chiropractic is the name of his clinic. But otherwise, hope you enjoyed.
Thank you for watching. To learn more from Dr. Scott, visit our site at optihuman.com.au.